This is a 62-year-old female with a painful bunion. As you can see, she has a large dorsal prominence here. She has an evidence of hypermobility, causing her to be prone to developing this large bunion. She's tried conservative measures of shoe modification as well as splints, all of which have failed, and she's here to address the bunion deformity. In the past, traditional bunions would be a large incision that's along the medial aspect of the foot, approximately 5 to 6 centimeters. Now, with modern technology, we're able to minimize the amount of dissection and as well as be able to do precise cuts and incisions to address the bunion deformity for a quick and rapid recovery. Okay, making a small stab incision under X-ray guided technique. We're able to do a small incision. We're carefully dissecting the surrounding soft tissues and neurovascular structures. We go ahead and release the dorsal soft tissue, only to control the sagittal plane itself. I'll take the burr next. Using a high-powered burr irrigation system, we're able to minimize our dissection and get a clean cut without causing necrosis of the bone. Once you find the trajectory of your blade, this procedure is usually done under a high frequency of X-rays to make sure that you stay in line with the osteotomy cut. There's four corners to the bone cut that you'd perform. The near cortex first, and then you come across. Once the osteotomy is complete, we confirm under X-ray. Still have a slight corner to fix, to release. And you confirm this the motion. You can see here that the capital fragment now is mobile. The surrounding soft tissues is maintained, therefore allowing to splint the osteotomy site. Next, what we do is we place our mosquito or curved hemostat within the osteotomy site, and we go ahead and we shift and address and correct the IM angle as well as the tibial sesamoid position. While retracting and shifting, we're able to address the position. Can I have a sponge, please? And that's the optimal position of your first metatarsal phalangeal joint. You see that the two sesamoids itself are well aligned underneath the metatarsal heads. Now I'll take the 2.0 non-threaded Steinman pen. Okay, and then we go ahead and find, staying extra periosteal with our placement of our pin. Okay, optimal positioning is obtained. We go ahead and place this in line with the osteotomy site. Temporarily take the fixation out the way. We place the mosquito back in. Once it's shifted in, you can see here, it's about taking this here. You're just gonna switch the instrumentation so that allow this to go into the shaft and advance it through the first metatarsal shaft. Once the positioning is confirmed on the AP view, next what we do is we take a lateral X-ray to make sure our sagittal plane is restored. Patient did have a dorsal medial eminence, meaning that there was some type of sagittal plane deformity. Therefore, the pin fixation will be placed slightly dorsal to address that dorsal bump. and hold the position in appropriate location. So the position of the capital fragment is in line. I also confirmed on the sagittal plane here, patient's first metatarsal is in line with the fifth. She has a rectus first metatarsal. Phalangeal joint, there's no more dorsal prominence at all as well. Her heel is well aligned with the forefoot, and that's a corrected bunion. Next, what we do is we advance it to the proximal adjacent joint to help increase the stability of the fixation. And that's it. That's your bunion correction. Tourniquet time is 10 minutes, but the bunion is corrected and done. You have very minimal incision. Should be able to heal and weight bear immediately after surgery. The pin will be removed at 4 to 6 weeks. And she'll transition into sneakers once the pin has been removed. So the goal of the x-ray, if you can see here, is to not only restore the first metatarsal phalangeal joint positioning, you have congruency along the first metatarsal phalangeal joint, your sesamoid position is well reduced, as well as the pin fixation is along the lateral corner of the medial cuneiform, and you have optimal positioning of the bunion deformity and fixation. We do a subcuticular closure with absorbable suture so that patient does not need to have stitches removed post-operatively. So the surrounding soft tissues will adapt and fill in to its new positioning. Patient did not have a bursa here, which was great. Therefore, it did not need to be decompressed. As you can see here, once again, to just review, patient has stable fixation of her bunion correction. She is stabilized and splinted distally as well as proximally. She has a well-reduced bunion deformity both on the sagittal plane as well as on the AP plane itself.